opinion is life's too short. Get started.
Is that what you're telling your son?
No.
Call the meeting to order, please. Do we have any courtesy from the floor? Okay. Update on Graysdale?
Okay, everybody should have a copy of the dashboard. Does anybody need a copy? No? Are there any questions about the dashboard?
1 second.
Sure. Oh, sure, sorry.
RN overtime hours.
Yes.
You want to talk about the increase this month?
Yes.
Last month.
Yes, sorry, for July. Yeah, we are continuing to hire staff. We are definitely on an uptick with that. Of course, there is the orientation process to get them in, but we do see that we will eventually have a decrease in our agency as well as our overtime.
Do you have a projection on that timeline?
Well, I mean, I think a month from now we'll definitely be in a better situation than we were in July. Like end of August, September, we should be definitely in a better frame
So we
of mind.
won't be reflecting that until October's meeting then?
Um,
Because a month will be September, we'll get that report in
Right.
October?
You know what? Let's be conservative and say that, yes.
Okay.
Any other questions? Yes.
On the admissions, something that I've noticed, I don't know if it's a trend or maybe you can confirm or debunk this. It appears that we are seeing an increase in the Medicaid admissions and a decrease in private pay since the beginning of the year. Is that a trend? Is that what you're seeing, or is it just random variance that's occurring?
It's random because, in all honesty, things do change month to month. Actually, we did pretty well so far with our private pay in terms of, the payer mix and also collections. We're upwards of about $655,851 from the beginning of the year.
Yeah, like I said, I'm just noticing the Medicaid ADC. Yeah, is it ADC? Went
Yes.
from around 500 like January, February to 538.9 in July.
Right.
Private pay went down from 124 in January to 99 in June and July. So.
Well, I'm sorry, go ahead.
Yeah, so I'm just wondering, is there a trend? We're seeing fewer private pay patients, and is there a reason for that, or do you just think it's just a random deviation from?
Most likely it's a spend down from people who are private pay to spend down to Medicaid. We also have had a decrease in our Medicaid pendings. Since a couple of months ago, we were up at 89, we're down to 71. So that is a good thing, in the sense that we're getting the Medicaid benefits, so this way we don't incur that private cost until we do get Medicaid. So it is that. We do continue to encourage to get in more privates as well, and our Medicare too. Actually, our Medicare for August is better than it was in July, so that's a big help as well. Any other questions?
It seems like pain numbers are up just a little bit.
Yes, they are. In our short-term rehab, we do have to accommodate for the fact that we get people who come in who are sicker and are in more pain, and we own that, and we do our best to try to relieve that. Long-term, it is pathological. As a person ages, things will happen, but we do have things in place to work with pain. We have our pain committee. We also have different interventions in place as well.
And it seems like the numbers for the antipsychotic medications have stabilized at somewhat, but they're still higher than what you would like your benchmark to be. So what have you done in terms of some of the behavioral health measures? Because I think we've talked about that more at the Graysdale specific meetings, but maybe in the public forum we could speak to that briefly.
Yes, we do have MedOptions, who is our new psychiatric and psychological provider. They've been with us since February, and they are They have a caseload that they've been seeing and trying to backpedal a little bit for people who weren't seen when we made the transition, because they really weren't supposed to come until April. But things did happen, and they are doing it, and they are reaching all of our residents and making sure wherever possible we can decrease the psychotropic use, wean them off to see how they would do. And I think the combination of the behavior management as well as the medication management is really a big help, because it allows you to use interventions other than medication to go ahead and try to calm the behaviors down.
Is there anything specifically that you're seeing or that you're using, or?
Well, I mean, like I said, we never had a clinical psychologist before whose specialty was in behavior management. We had clinical social workers who were able to go ahead and provide psychotherapy for people who were depressed, but they didn't have the behavioral management techniques that we have now. So that is that's definitely a huge plus in our favor.
So is your psychologist doing more interventions, or are they doing more behavioral plans?
Initial behavioral plans and interventions for the staff to help deal with the residents.
Okay, thank you.
Yes.
Yeah, just a couple more things with the nursing overtime for July. Did you already talk about that? Or no?
Yes.
I thought I did, but
Oh,
go
you
ahead.
did? Oh, okay. I'm just wondering, was there an extra pay period, or was it because of the holiday, or?
Well, we did have July 4th.
Okay.
And also the weekend before. And, we've had the holiday. It usually does affect it. And there was a couple of other things that also affected as well. The staffing that we have and trying to fill the positions that we have.
And then the last one I had is the CMS star rating. We seem to be stuck at 2, and I believe that regulatory compliance is the number that I would like to see move or improve. What are we doing to move that up and get the star rating back to 3?
Well, in
We talked
actuality,
about that.
I'm sorry, what?
Go ahead.
Oh,
I'll
sorry.
let you say that. I thought we talked about that before, but go ahead.
Yeah. Regulatory compliance, that usually comes when we have the survey. Premier just did its mock survey, and to go ahead and help the staff get ready for the survey process, which could be any time November, December, January, up until it's 14 months from the last time, and they were here in November. So they have identified several things that we need to work on, especially in nursing, and we do have our new director of nursing, and she will have a nice way of saying exactly what needs to be tackled, for our residents. So that's a big help for us.
I see Jen smiling behind you. Do
Yes.
you want to say anything about that? Or?
So far, so good.
Keep smiling. Yeah, my understanding was those numbers aren't really going to change until the state comes in and does the survey. So
Right. I mean, we could have a change in our quality measures if things continue to improve, but unless you have a 5 in quality measures, you're not going to see a 5 stars. You're not going to see an overall star rating go up 1 star. And the same thing, staffing. When we improve in our staffing, that is a good opportunity to see the overall star rating go up if we're able to get back to 4 stars on the staffing.
Any other- no more ice cream social elevator log jams, or
Definitely not.
take it to the floor.
Are there any other questions for?
Yes.
Yes.
Hi.
Yeah.
Sorry. I was at the CCAP convention that just passed month, a few weeks ago or last week.
Mhm.
Anyway, I went to, they had a breakout session on county nursing homes. And a lot of this we'll get to as we go down the road. You're aware they did a lot of talking about community health choices
Mm-hmm.
that's coming in. And also about some of the different situations. There's been problems with texting of doctors used to be able to order text orders. Now HIPAA has said, no, you can't do that.
Correct.
Some homes haven't caught up with that. I assume we have.
Yes.
And,
We don't text orders,
good,
actually.
Good.
Yeah.
So, I mean, there was something they said, and I wasn't exactly sure, and I thought maybe you could help me, and that was identifying high-risk areas. They are, when I say they, I'm saying state, whatever regulatory, are interviewing staff families and not just looking at records now. And if the fine is over $5,000 in some area, you're not allowed to train your staff yourself for over 5 years. Is that something that we're aware of?
What fine are you talking about?
Well, regulatory compliance.
You mean a civil money penalty?
Fines, denials of payment, loss of high mark contact, labor market. I'm just asking you, it says identifying high risk. I'm assuming that this is regulatory. I just thought maybe you could help clarify it.
Well, I mean, it really, because there's fines for different things. If it is regulatory, that probably wouldn't make any sense because you have to train your staff in order to be able to improve the situation if you do entail a fine. So maybe it means something else.
Well, I guess it's the part where for years they look at records and go over that. I don't know if this is a recent change or it's has always been going and I missed it, or it's something that's coming. And that is that they are doing more interviewing of staff, families, taking that into account as opposed to just the records, just
Right.
the paper
And,
trail.
well, that in general is what's being done. For example, for the new survey process that we have, they are interviewing more residents and families and getting a better idea of what's going on with them as opposed to records. So that's in line with the new state survey process.
Okay, all right, and so.
Sorry.
No, that's fine. That's why I'm sitting here and you're standing there, and
Okay.
you're helping educate me. Yeah, they did talk about some of the issues that we've talked about over the times, and I have to dig into this more to get more out of it. But what they did talk about with the managed care coming, and the idea that the community health choices is not going to be forced to contract with any home. I mean, so it almost becomes a competitive type of situation. In other words, it's not set in stone,
Right.
just because we have a county nursing home that we're going to get a contract. And without a contract, we're not going to have much business. So I'm just saying, I'm sure you're on top of all of this.
Yeah.
Okay.
Well, I mean, I was actually talking with Ed Frigo. He is the financial liaison for Premier, and
Okay.
he had just, educated me and indicated that, effective, January 1st, 2020, we are going to have 3 companies, UPMC, PA Health and Welfare, and AmeriHealth come
Right.
in, but the facility cannot be cut out for the first 18 months in terms
Okay.
of their rate. All right. Our rate of reimbursement will be based on a rate of calculation of the 4 previous 2019 quarters of the calendar year. And after that, Graysdale can negotiate increased rates for the MCOs, managed care organizations, which would be distributed in the IGT assessment payments.
Okay.
So, well,
Yeah, and I think, I know I've had a conversation with the county executive on this, and I think we know, moving down the road, I get the sense Graysdale is going to become more and more the go-to facility for the poorest, the most ill, multi-issue resident.
yes.
And I'm just wondering, as we go forward, and you go forward and we're negotiating, is that going to play against us in a sense of reimbursement or?
I don't think so, because of the fact of the population that we serve,
Yeah.
that most other nursing homes don't serve. And if anyone's going to be hardest hit, it's going to be the more private organizations that are more in line with the short-term rehab units that are mostly all short-term rehab, and they feel it too. They know that their time is coming where they're not going to be able to get those residents anymore. Us, we will continue to be able to take our residents and take care of them as we always have.
Okay, well, and I appreciate it. I mean,
Oh, sure.
it was very interesting, illuminating. I remember back in the day when you'd go to something like that, it was a filled room. But now that there's only, 17 or 20 counties with 17 with nursing homes, the room was fairly empty.
Right.
But there is still there was some issues and concerns and about how this may or may not play out. And I guess you're in touch with Pasha and you deal with them.
PACA, yeah, PACA, yeah.
PACA, I'm sorry.
Pasha sounds better, actually.
The acronym, yeah, that's the other one. And you live and die by acronyms in human services. So
Yeah.
you get away, you try to get out of your head.
Oh, yeah.
But anyway, okay, well, I appreciate it. That was all I had.
sure.
Thank you
Absolutely.
very much. Thank you.
Anybody else? Okay. Thanks, Ray.
Thank you so much.
Health Choices Division?
She's back.
She said she would be.
Good evening, ladies and gentlemen. I'm Deborah Nunes. I'm the coordinator for Health Choices for Northampton County. I've provided you with a 3-page summary. I didn't know where to start here. I didn't know if you wanted a Health Choices 101. But basically what Health Choices is, in case you do want one, is that it is the managed care. The managed care came to Northampton County in 2001. They gave the counties the option to participate, and the county said yes. So our division was developed, and now what we do is we work with the managed care organization known as Magellan. We oversee everything that they do. They hold the contracts for the providers, they do the audits, they do the technical assistance, they do the quality control, they do everything that the state has asked in our regulations to do, and then what we do as a county is make sure that that's what they're doing. And we have a 4-person unit, including myself, to do that. So we go out and participate in audits with them, and we have caught some things that Magellan has not caught, and we've rectified that with the providers. We've also been looking into timely filing and claims. A lot of times the providers they provide the service, but they don't file their claims in a timely fashion. Therefore, there's a lot of money laying on the table, and if I was working private, self-employed, I'd want to get every penny I could get for everything I did. So there's many, many, many different dimensions to this. So we are basically the behavioral health. They also have a physical health, which is Aetna or Gateway, so it covers all their physical stuff here. And on the second page of this thing, I have the most current numbers that we have. The number of Northampton County eligible MA recipients as of 6/30/2018 is 50,083, which has grown from 2015, which was 46,736. And I do believe we will exceed 50,000 in the next 6 months. Now, what that just basically means is there's a lot of people that are eligible for medical assistance, but that does not mean that everybody that gets medical assistance always uses all the services for behavioral health. When it speaks of a penetration rate, we have about 11 to 12% of that total thing that uses the services that we have. But the more they use the services that we have, the more expensive it gets. Right now, our biggest cost drivers are inpatient, and I can go into that in a minute, and our detox rehab for the opiate crisis. With the people that are in the inpatient, we are finding they have longer waits. The kids have longer waits to get into residential treatment facilities, most likely because their behaviors are too acute. They're very aggressive. These kids are getting bigger than they used to be when they were younger. Some of them have autism, some of them don't. We also have the dual diagnosis, MH and DP. And their acuity, a lot of the RTFs say, oh, well, we either don't have room or we can't take that at this time because it would mess up our milieu of the people that we have or something else. So as long as they have the right to refuse, these kids sit there for 3-4 months. With the adults, it's not much different. We have MHID people that have been more aggressive, and they're getting harder to place because we have to work with the ID system, which is going through its own changes and not really helping us all that much, but we are still sitting down at the table trying to find solutions for these issues. Us and Graysdale, who was before us, in the grand scheme on page 1 of Human Services, if you put both of our budgets together, we probably make about 72% of the whole thing overall. So just letting you know where we sit in perspective with everything else. And on that third page, since I've been in here, and it doesn't count any of the stuff that was done with Allentown State Hospital because that was done before I was coordinator, these are the projects that I have put in. We have 3 goals as Health Choices. One is to improve the quality of the services out there, make sure there's access to the services that are out there, and try like heck to make sure it's cost effective. A lot of times through reinvestment, and what reinvestment is after our whole fiscal year is done and the state looks over everything, we are allowed to keep 3% of whatever we've earned to use as reinvestment. Reinvestment is to be bringing new services in, try pilots of stuff that we haven't done before, and hopefully they will sustain themselves and then roll into our capitation. So up until 2016, I put about $7,118,737 in trying to bring some of these things to the county. Our extended acute care is up there at Hartman's Ice Cream. It's a 6-month program for people to try to divert them from Allentown State Hospital, well now Wernersville State Hospital. Our lodge is our consumer-run supported employment program that's out in the south side. You might know them as Cafe de Lodge. They usually do a lot of our catering for some of our meetings and stuff. School-based outpatient, we put into Liberty High School the first year, and we put it into Freedom High School the second year so that we could have more access to the kids coming in and getting their meds and the doctors and therapy as opposed to no-shows if they had to go get it at a regular appointment. It also includes elementary schools, middle schools if they want to use that school-based outpatient. School-based outpatient expanded, it's the second one. Affordable housing. I have an affordable housing, it's in year 4 of 5. What I do is I screen the people that make sure that they have the MH, they're residents of Pennsylvania or Northampton County, and that they have the diagnosis, and I subsidize them in order to bridge them so that they can go ahead and apply for either Section 8 vouchers or public housing. By virtue of doing that, if they get that and they go on those programs, they get off my dollar and they get on theirs. So we're in 4 of 5. I don't know if we're going to go past 5, but we've served over 76 people. We have family units of 3 bedrooms so that people coming out of drug courts, et cetera, can be reunited with their kids if they do what they're supposed to do. And we're looking to see what else we can do for these folks. The MHID, in mental health, we have the highest intensive level that we can give is called the ACT teams, the community treatment teams that go out and they have the therapist and they have everything. Well, we did the same thing with DDTT, dual diagnosis treatment teams, so that they can go out and help the MHID population. And when they are going back into the community from a hospital, et cetera, these teams are meeting with them and going back and meeting with the providers to transfer the skills so the person doesn't have to get readmitted into the hospital. We tried the non-hospital detox and rehab. Zoning blew that out of the water. We couldn't get that going. But what I'm going to be doing with that $500,000 now is I'm presently writing a respite plan. Northampton County hasn't had respite for a long time. Access Services will be the provider. I'm looking for a 4-year contract with them for not only children but adults. And we had a pretty robust one before. Hopefully we can get this off the ground for at least another 4 years.
Could I stop you there for a minute? Can you clarify what you meant, that they put a pin in it, or could you double back and say?
Well, they had a campus up in, with this opiate crisis, they had a campus up on Stroudsburg. And because they had already been approved for zoning, et cetera, they thought it would be really easy to put a couple more buildings on that campus and then be able to give us at least 20 beds for Northampton County purposes if I contributed to them with the reinvestment dollars. But what happened was they were hitting snags with the amount of people they'd be able to see, sewage, zoning, regulations, et cetera, and it kept on, getting continued. So after 2 years, I had to tell the state, we're really not moving on this. I have to do something else.
Thank you.
Yep. And the autism 2-to-1 team approach is something that's right outside the box. This is for autistic kids that are either coming out of the RTFs into the community or in the hospitals. They need very special training. They need certified applied behavioral analysis, which is what ABA is. And this is a pilot program for 2 years. We served our first kid successfully. We now have a 7-year-old that we're working with that is very aggressive, beats on everybody. We just started with her. We're going to get her reevaluated and see if it isn't something else. And then we are going to try to, the 2-to-1 means that if they're having problems even at night and not sleeping, you can have 2 staff to the 1 consumer and hopefully transfer the skills to the parents so when we have to pull out in 6 months or 7 months, the parents can continue the success with the kid. And that's about all I have unless you have questions. I knew you would. Go ahead, Ron.
You're helping me catch up.
Okay.
What's our reinvestment fund as a town? What do we have that you haven't allocated?
For reinvestment, right now I have about $3 million.
Okay.
But I have to wrestle with the state because they say if you don't use that within 2 years, you may have to give it back. And now that they have all these changes with new people, they are sniffing, yes. So I told them about the 500,000, they can't have that because I'm doing the respite, but,
Yeah, I think
yeah.
as long as you have.
Yes.
You lay out some plan. This program now is what, it was started 2000?
2001.
2001, yeah. Is it still a deal where we go in with Lehigh County to get a good rate with Magellan? We go in with a joint?
Actually, no.
We don't.
No, we have our own rates, they have their own rates, and the state really looks at those too. Even though they might have more money than we do and they have double the amount of members, they know they get their own rates and we get ours.
Now, but I'm one of the early problems was, and that's why I'm asking, because by now it's Eve programs moving on. But I remember we used to have to get into some issues with any provider, Magellan, for example. The rate that the state would give, they'd want as much of it as they could get versus what we'd want. And, I mean, we usually, well, we did come to agreement sometimes after some tense phone calls. Is that sort of still the process, or has the state clamped down and more restrictions?
The state has clamped down in the fact that they don't allow a negotiating period anymore. What they do is they look over the program. We've been in existence since 2001. They look over the maturity of the program. They look over the data, the claim, everything. And then what they do is they give a capitated rate. And if we've had a few things that we've at least incorporated in a letter to them, like would you please look at this, the PLE, would you please look at this? A lot of things have changed as far as gross receipt taxes are now called MCO assessments, which are twice as expensive as what it was. So we have to do with whatever they give us and whatever they pass through. And even now, which you may not have had in your tenure, we have a 2-month delay in getting paid.
Oh.
So each May and each June, we do not get paid. We have to hopefully use the reserves that we have. And then in July, they give us a big one. Of course, it messes up everybody's fiscal years, and then we can go back and fill everything. So, yes.
Okay, well, see, you're never too old to learn.
No.
And as Mr. Kusick would say, this was a teachable moment for me, so thank you.
Anyone else?
Just two things. The contract with Magellan, is that a competitive bid or competitive negotiation? How do we award that contract?
That was in the past when we first started, and I think we did one more RFP in between. But as things have changed, we have stayed with Magellan. We haven't RFP'd them for a while. Lehigh has RFP'd them and told us what a sad showing other people other than Magellan is. So you kind of get stuck between the demons that you know, and if you went for somebody else who could come in and give you a ballpark of a lower rate, you might get what you're paying for too. So between our solicitor, between our auditors, whatever, we've kind of just stayed the course with Magellan.
Well, you know, they may be doing a great job, and we went through this recently with Premier. It's always good to go through the competitive bid process, just so you know what's out there, and to keep your current provider, you know, honest and up to spec. So I would like to see that competitively bid rather than just awarded continuously without one. The other question I had was for the reinvestment projects. $3 million is a lot of money, and I think these are all worthy projects. What is the process that you go through to decide what you're going to fund? Is there an RFP or RFQ?
That comes a little later. It depends what you're doing. For instance, we have meetings with our Community Health Choices Alliance. We have meetings with our Health Choices Advisory Board to try to get input from the stakeholders as well as providers as to what they think we need. They can make suggestions, et cetera. We look at it. We assess to see if there's a need, if there's data that shows it's a good idea, and then it might sustain itself in the couple of years, because it can't be on our dollar all the time.
Mm-hmm.
And when we make the decision about what goal we're going to go for, we have to write a plan, submit it to the state. The state has to approve the plan with a budget, and then once they do that, we not only have access to the money to be able to do something with this plan, but then that would be the point that we would do an RFP if needed, or we would utilize a provider that's been providing the service maybe somewhere else that has the experience, because sometimes it takes 2 years to build something up where you have somebody who's already doing it. The DDTT is one of the ones that we brought in because there was only 2 providers doing it in the state. Marikey has that now, which used to be Northwestern Human Services. And then we go ahead and we just do the timeline and try to get through the plan for the 2 years. If I need to go ahead and ask for an extension with the state, I can. If I need to ask to put more money in the plan, I can do that,
But,
but not without their permission.
okay, but ultimately, you're deciding what you're going to pursue. There's not an open call for.
Again, it depends on what the service is. We have RFP'd, right now we're RFPing for a specialized RTF for kids because of the issues of others ones not wanting to take the aggressive. We have also done a recent RFP, interest rather, to all the school districts to find out who's interested in participating, having more school-based outpatient in their schools. Depends what the service is. The DDTT, since it was dual diagnosis, and you need to have the specialist for the psychologist or psychiatrist that knows both MH and ID, that's a little hard to come by, so it might be better to stick with who's doing it.
And last question, since Medicaid expanded, how has that affected your office?
It's affected our office as far as having more people to deal with. It hasn't affected our office as far as having more money. But the state has been putting more initiatives, and with the expansion, like the tobacco cessation, we had the integrated physical health and behavioral health that the state just mandates these things. So as they do that, we're trying to do everything we're supposed to be doing, plus the new projects. And we don't have a whole lot of people in the state level above our regional office that, how can I say this politically correct, know what they're doing or able to make the great decisions.
That was very savvy.
That was just correct.
That was kind.
I left out the bad words.
Are adequately informed, I think, is a
There
better
you
way
go.
to say
Thank you.
it.
Finesse, finesse.
Madam
some-
Chairwoman? Oh, I'm
I
sorry.
have some questions.
Oh.
When you talked about the Medicaid expansion and all the Medicaid numbers, those are like not temporary Medicaids. Those are like long-term disability, long-term,
Yes.
not short-term folks.
No.
According, you were talking about the numbers and the beds. Do you find, especially with the youth population, there's less available? Or is this, because of this program, are you always working, or are people working with you to create more beds? Because I've just found that there are less places to send people. There's less programs available. There's programs that have closed since probably 2001. So,
There have also been programs that have been closed since 2001. We've been trying, we haven't tried to do the buy a bed, reserve so many beds, because it's not really practical, especially like with the hospital. They're always full, pretty much. And to ask them to save 5 beds for us just in case, that's not going to work, especially at MA rates, when they can be filling them with private play. We have reached out to the providers to try to get them to think outside the box and not keep doing the cookie cutter services, to try to take a risk, and with our help, whatever, try to do something better, try to take a specific population. That's with minimal success, because we don't have the support on the other side. I don't know what the answer to that is, because it's been our highest cost driver for the last 3 years.
I think especially with youth. And are you on the, is she on the committee with us? Are you on the committee with the Stepping Up initiative as well? And I guess my question was, are these just for non-adjudicated folks or adjudicated folks here too? Because we've been talking a lot about the mentally ill and criminal
We work with
combined.
the forensic. With my housing project, it's for both populations, and we try to help both the MH court and the DNA court, with the difference being that the MH court is not a diversion and the DNA, well, no, the MH might be, the DNA is not. Most of the forensic beds that we have are the women that are coming out and trying to get their lives together so they can get reunified with their kids. We have specialized ICM right now, which has just stepped up to the plate in the beginning of July, working with Laura Savinelli in the prisons. And they have stepped up to the plate with another provider called Holcomb. And what they were trying to do is help get these people out of the prison as quickly as they can. And if they needed anything with the medications, et cetera, Holcomb has the outpatient, and they could put that together as well. So we have that initiative going. We do work with the DNA office when they got the jail diversion, as far as when people were in the jail, then they could get the expedited approval for medical assistance so they can go right into rehab. So we had to track that for 2 years. So we do have a pretty good, with the DNA and any of the forensic. We've been working with mental health for the forensic. But I will probably be in the stepping up meeting tomorrow. They're drafting me.
Okay. Take my place. I won't be there. I just found out about it right now. I don't know. I think you had another question.
I was when Mr. Cusick asked you about, going out, and I know when we first did it, there were like a group that came and they wanted to. I don't know if you remember, Value existed. They were out in the Pittsburgh area, and
I think they might be done.
Are they dead probably by now?
I think.
I think one of the problems we faced, and I don't know if it still exists, is I guess I can only liken it to our health networks that we have now, the St. Luke's network, the Lehigh Valley Hospital. And what we found, I know after the first contract term, I think was 2 years, because we changed, it was the way the county had done things forever, and Health Choices came in, and boy, did that change things, and people weren't happy. So the assumption was that Magellan's was terrible, and somebody else could come in and do a better job for a better a rate. But what we found was, when we looked into it, and I think Lehigh County was more aggressive with this, was Magellan had a better network here. And so I wanted to just say, when we talk about cost, we're talking cost-benefit, because while I know it's cumbersome to put together, I have nothing against going out to bids and seeing if the costs are still valid. But I'm just wondering, we're talking about services, we're talking about lives, we're talking about situations where if you pulled the plug on one group, you've got to come up then with maybe an entirely. Oh, I'm sorry. Is there?
No, it's okay.
A little bit of a.
My leg. That's
Oh.
Deb's got a bone leg.
Well, why don't you sit down? Bernie will scream, but just sit down.
I'll scream.
I'll paraphrase what you say and hear, and Bernie can hear you.
Go ahead. Thank you.
Thank you.
All right. Well, she can. No, I guess my question is, I think I'd like you to just take a moment, Sue, to just explain that the money end is important, but I don't even know how many competitive companies would exist today that would bid on this, and also what happens. You've already established these networks. If Magellan went away, not that the world would end, but it certainly would change the way you do business.
The other ones that are out there are CCBH, and I think it's CBH right now in
Okay.
this area that made the bid when Lehigh did their RFP. And the only reason that Lehigh did their RFP, from my understanding, is because their commissioners decided to do that for every level of service that they have.
Oh, okay. And I guess by now they probably are. There's more companies maybe that are.
There might be one, not many though.
Yeah.
67 are basically still covered by the ones that they've been doing. There's only been a little bit. As a matter of fact, I think Magellan just acquired their 6th county 2 years ago, after a 15-year.
Yeah.
So what would happen is, if we went RFP and we decided to pick the lowest bidder, we would have to inform the state. We would have 6 months to end with this one and start with that one, and get everybody on board and all the providers. It's a very expensive endeavor.
Well, yeah, and I know some of the contracts, when we were looking at Value, for example, it sounded good, but we looked at the contracts, and at the back end, we were nervous because it was sort of like a teaser rate for services. And but again, at that time, the problem was they were coming in from the Pittsburgh area. They didn't really have the contacts. Magellan seemed to have done their homework and set up the systems. Now, I'm not saying they at this point in time, there's not somebody that could do it better, but I just think that there is that benefit or the programmatic side of it, the programmatic side. That, in fact, if you do make a switch, it could have an impact on some of the services and the people that get those services. That's all. It's a consideration as well as money. I mean, isn't that correct?
Yes.
Yeah, that's all I wanted to be sure of.
And if I could just clarify, I don't believe you have to take the lowest bidder in this case.
No.
There's other components that go into a competitive bidding process besides just price for services.
Well, I think we've exhausted our questions and your
And her
standing
leg.
ability,
And her
and I
leg.
apologize for not knowing that. I want to thank you for what you do. I want to thank you for this report. I mean, it's a daunting task, and I think you're doing really well with it. And I'd just always be curious to hear what new ideas you have for that $3 million, especially in terms of housing, because I just see the housing and all that kind of stuff drying up more and more, and everybody's looking at acute care, and it just doesn't cut it. It just
One of
doesn't
the
cut
other
it.
things is I would like to get more services over here in Northampton County.
Absolutely.
And if that's what I can do, that's what I'll do. But if you have any other questions, whether I'm sure you know how to get in touch with me.
No, thank
Thank
you.
you very much.
Four-person staff, thank you very much.
Madam Chairwoman, just very quickly, Mr. Cusick, no, it'll be really
I'm
quick.
kidding.
Mr. Cusick and Mr. Heckman's questions and the colloquy lead me to an offer I'd like to make to the committee, because I agree with Mr. Cusick. I mean, I don't understand the human service contracting process myself, and I was going to convene the directors, who, by the way, are all tremendous professionals with the highest ethical standards. I don't think anybody's questioning that, and I don't even think anybody's questioning their judgment. But they're having been in this job now for 7 months and signing all these human services contracts with providers I have absolutely no idea about. Okay, I'm signing contracts I have absolutely no idea about, and I readily admit that. I think it would be healthy for this committee to have the directors in and ask them how their contracting process works. I've never understood why the charter exempted human services contracts from the regular contracting provisions of the county, and I frankly the courts either. So I think it would be very good to have and we should probably do it on a day when we're not doing anything else. A day when we have
Tomorrow after 1:30.
a day when we have these highly skilled, highly trained professionals with great qualifications come in and explain to us why they pick the providers they pick. I think it's important for transparency's sake. You're talking of millions and millions of dollars here, and kids and folks
agree.
and retired people's lives. So I'm sorry, I don't want to take up any more. I just
Okay.
wanted to let council know I agree that there needs to be more transparency in this process.
While you're walking to the mic, you and I have already had this conversation earlier on, and I didn't want to toot her horn, but we've discussed, as we both go through this process this year together, to get a year in and to start to look at who are the
Absolutely.
providers, who are getting the contracts, are we satisfied with their work? And not just in your department, but all
No,
over.
across
Like I
the-
see
across the
Pyramid's
board.
name all over the place, for example. Are they really giving us what we expect to be
Right.
getting? Is there somebody out there who could be doing more than that? And so we talked about being able to start vetting that after this year. So
Absolutely. And Mr. McClure and I had that conversation not that long ago in terms of him getting a better understanding of the process. I have somewhat of an understanding at this point with some of our divisions, and you have Deb's unit that's just Magellan, and you have Children and Youth who has, I don't know, 75, 100 contracts. I mean, there's just, so if you provide foster care services in the Lehigh Valley, unless you are the Impact Project, who we will not contract with, we probably have a contract with you. Now, if you're not providing good services, we terminate our contracts. But it is a different process, and I've participated in some of the divisions vetting, I guess, so to speak, of those different vendors, but it's detailed, and it would come best from the administrator. So we definitely can do that at some point. So when you asked that, Mr. Cusick, I knew exactly where Mr. McClure was going to be heading there. So the good news is you're not alone in asking those questions, and I agree that even though I'm very comfortable with the processes we and Mr. Heckman knows have always done, you all need to know about them, and the public needs to know how we do that, and that's what's important to me.
One of
So,
the first conversations Pat and I over was her how she was going to handle the kingdoms, because she found out the different divisions. They have their own little fiefdoms, and sometimes a director is not necessarily given a welcome sign when they start asking questions, but that's part of the job. But no, I agree. I would just say if council wants to, I don't know if we were talking about approving every contract. I would say be careful what you wish for if that's the case, because you could spend forever approving 7,000 here and 5,000. But
it's probably not. I mean, listen.
I mean, in the number of vendors, but
I think it's
but it's a
more
good.
of a-
There's nothing wrong with reviewing. I'm all for that. That's fine. Good. Do it.
Yes, absolutely.
I think it's
Process.
just something down the road, and we've begun that conversation. I think
And it will continue.
everybody wanted to see, we wanted to get everything up to speed, but, there are complaints and there are visions of who's good, who's not good, who's, like you said, mediocre, and so we'll do that. Do you want to get back to the agenda of information referral, or are we going to table that till next
We
month?
will. We moved Mr. Rushman. He's under the weather,
Okay.
so he was unable to be with us tonight.
So?
And thanks for Deb hobbling through. I appreciate that. Once Mr. Heckman had another question, I thought I should intervene. So
Well, why don't you give your report,
I shall do that.
and then we'll take questions after your report.
Okay. Just to follow up about two things on the Graysdale. One of the things I noticed when we actually went over some monthly reports today was the use of psychotropics seemed to spike's too strong of a word, but there was a decent jump from February, March into April, and you've heard about med options, and I think I've talked about this, but ultimately we had at least 2 psychiatrists prior to having a contract with med options who for their last few months of their contract just didn't really come to Graysdale, no matter what we all tried to do to implore them to fulfill their obligations. So we had, what's that, Mr. Kraft?
Then you shouldn't pay them.
Well, that's a good point. So I don't know that we paid them because they weren't there, and you can't bill for a service if you're not there. So that's entirely possible. But as a result, they were there some of the time, but certainly not more than probably half of the time. So we worked getting med options in there 2 months before they were really supposed to. So I think part of that initial spike was because there was a fair amount of folks who hadn't been seen for a while. And so once they were seen initially, there were some folks who definitely needed to be on medications. And now that we are there, and Med Options has been there for a little while, now we're able to look at some more of these psychological behavioral interventions, which hopefully will continue to then bring down the use of the psychotropics. So, and there's also the use of Compazine for nausea, which is really an antipsychotic. So I don't have all the details, but I know we discussed that, and that impacts that number as well. So any questions about I just wanted to mention those couple things. Okay. Sort of follow up then and piggyback off of Deb, I'll start with our mental health division. One of the things that I'm really happy about is the collaborative efforts, not just amongst the human services divisions, but across the county. We had a cabinet meeting the other day, and going around the room, I said I literally have worked with every person from every different cabinet on at least one project or another. And so we're really excited to be sort of joining forces and having all the right players in the room. Stepping Up initiative is, sort of just one example, but housing is a big focus, and the forensic beds that we've talked about, trying to get these folks with mental illness out of the jails. So we actually are just submitting a proposal to OMSAS, Office of Mental Health and Substance Abuse Services, for a forensic housing program. So it's for another LTSR, long-term structured residence. So is that correct, Deb? Yes. Thank you. That's good. So it's about an 8 or 10 bed facility, but this would be, it's one we established one initially when the Allentown State Hospital closed. Generally, the only way you can open another one is if you continue to give up more of those beds. So this would be a focus on the forensic folks. And so I think it's Monroe County got a very sizable amount of funding from OMSAS. And so once I have a Kathy Cromer case, one of our mental health caseworkers, is really up on all the housing stuff. And so when she heard about that, she took the initiative to work with our mental health administration to submit a grant proposal. And that could end up being a couple $1 million. So we're really keeping our fingers crossed for that. But that would end up being a collaborative effort with Deb and Health Choices and Maria with the Public Defender's Office and, court services. So we're pretty pleased with that. So fingers crossed, hopefully. I think we find out fairly soon. So if we're really lucky, I'll have good news by next month. And I know I have mentioned this overlaps with Graysdale too, the mental health aging program that we put out the RFP for a team of folks who will be piloted in Graysdale to help with the behavioral psychological interventions with those folks. So those proposals are, I want to say they're due next week, sometime in the next week or two. So once we get those, we'll be reviewing those and choosing some folks to interview and selecting that. But the hope is that program will be up and running by the end of this calendar year. So, and actually that got some national press with the McKnight's newsletter, which is a national press for long-term living facilities. So we've already had a fair amount of follow-up from that article with folks wanting to sort of piggyback and what we're doing. So that should be, we're excited about that. And along with the housing, we're trying to restructure just a very small amount in our mental health division. We have someone who focuses on housing, but it's supposed to be a small portion of her job. I mean, we could probably have a half a dozen full-time people working on housing, which, don't worry, I'm not coming back to ask for. But we're talking about figuring out, identifying one or two people who, just shifting roles, can really focus on housing across all domains, not just mental health, not just aging, but you might be housed in the mental health division, but it's sort of overarching all of the other human services divisions. So that's certainly one of our focuses as well. I wanted to just give a brief follow-up about the Veterans Division after last month's meeting when Mr. Ramirez presented here. So he and I met very soon after that, and we discussed the importance of making sure we're collecting data and tracking things not just on paper, but electronically in some capacity. And he had said that he had been told that previously that was not necessary, but I assured him that we would need to do so moving forward, and explained that if he would ever like to add another service officer, the only way we can do that is if we have the data to support the need. And I would like to come back and ask for that position at some point, because that would mean we're doing even more to help our veterans. So the data is part of what is needed to apply for grants, obviously, as you all know. So at the moment, we really wouldn't even be able to do that. So we're looking at two different options for how to accurately capture that data that's easy to use and cost effective. So stay tuned. And Mr. McClure has tasked me with the request to tackle veteran homelessness. So Mr. Ramirez and I learned of a potential joint venture with Lehigh County for applying for a homeless grant program for the vets. So I had asked for information to share with you all about that tonight, but I don't yet have that, so I will get it to you.
And I know I talked to Lori about it. I'm not sure if I said it before, but the Valor Foundation, I don't know if you guys have spoken to them. They kind of started up in Monroe County. They actually started, they have I think it's a 12-person bed that they actually go around and they went around and they deal all the way from Stroudsburg down to Allentown with homeless vets. I mean, they literally go out under bridges and go out and find them. And so many of the homeless are veterans that have come back. And so, maybe a third. But, I mean, they do what they call stand-downs in Bethlehem and a few other locations. And they come in and just line any homeless, and they really go out for veterans. But any homeless can show up and, they give clothes and food. And for veterans, they find in the wood that are hard, not ready to come back in.
Yes.
They give them tents and sleeping bags and stuff to get through the winter. So
Sure.
under the last administration, they actually tried to put a facility in Northampton County and didn't get much support. So I'd be happy to share. Mark Bayless is he heads and so they have this whole, it's I don't want to say a 12-step program, but they go through a detox. They spend a short amount of time in this facility and kind of getting back on their own, and which includes how to fill out the paperwork to get all the services that the road, which is really how it all started. Was he was a veteran and he was daunted by all the steps to get through it.
Sure.
He understood it and is now helping others do it.
Great.
And then they also help find work and then housing afterwards and so they do the whole process. I said that they're in Monroe County right now, but I know they would love to be down here because they do a lot in the county already.
Well, absolutely, with that overlap up that direction, I will follow up
Yeah.
on that.
And I can send you his information
That'd be
if you
great.
spoke to him.
I appreciate that. That would be great. On the good news side for the Veterans Department, Freddie talked about, obviously a lot of what he does is helping people fill out their paperwork to collect benefits and file claims and all of that. So he gets a printout. I don't know if he gets it quarterly or yearly, but last year, Northampton County, which really is through Freddie and his assistant Stephanie, Northampton County helped veterans collect $3.5 million in claims. Even more impressive is Lehigh County's folks only collected $4.2 million, and they have 3 service officers to our 1. So I said to Mr. Ramirez, you should have told council that's really great, and that's a lot of what he does. So we really would simply like to expand upon what he's already doing, and I'm willing to come back and ask for another service officer if we can have the data to support putting additional programs, grant-funded programs into place. So stay tuned. Any questions about that?
Yeah, I have one for you.
Sure.
I know when I was in there, he has all kind of files and all kind of records. It's like scrapbooking. Any veteran that got out of the service, like Mr. McGee or myself or whatever, they have a file on if they live in Northampton County and they have all the news clippings and everything. Is that something our archives should be taking and archiving, like making digitized pictures of and scanning so we can get access to people's names? Like, my dad got out of the service as Eddie Kravchak, and it's in the files somewhere, and I'd like to be able to go in and find it without going in, finding us people in the office and going looking through files. Because Steve Barron did it, and he found things from it's kind of interesting.
You know what? I believe he's the one who mentioned it to me. I will follow up because I believe what I was told was. Never mind. I won't repeat what I was told.
Okay, but we have a great archives place that we could do the digitizing and scanning and digitizing everything. And we built the building. I don't know how busy they are.
Well,
there.
when we moved to the Human Services, don't say archives in front of Mr. Derringer. But when we moved to the Human Services, I was told that maybe they didn't want to take all of that stuff with them, and I was told that maybe somebody else said, "Then I'm taking it with us." So. I think we have all of the things you're referring to.
I think they have all the stuff there. There's files and files and files. There's a lot of it. I mean, even when Mr. Heckman got out of the service, they have it in there, I mean, it's there. And that's old. That's a long time ago.
Oh, dear Lord.
And if we don't have it, then I'm just
But it would be nice to
clear of me.
digitize it all.
My father, I went in way, as Mr. Kraft would say, way back in the day.
Discharge.
They had an news article that was on file about when he was in a building in France when it was getting bombarded, and they mentioned his name and that. And I was fascinated. I didn't know that they had things like that. And,
Yeah, you never read those. You can't. You find so
Oh,
many scrapbooks.
absolutely.
You might find on somebody or one of your relatives. So
Yeah.
I agree with Mr. Kraft. It'd be nice to consolidate that.
I
if you know
would,
where they are.
I would agree, and that's an excellent suggestion. If we can avoid the archive, though, that
Thank
would
you.
make.
But thank you. That's all I did. I
Mr.
want to move the
Dirty
meeting
can
along.
work
It's already
on
6
anything in the
o'clock.
archive.
Let's stay in order, please.
That was my only question.
Out of order.
I think I'm going to start going first.
Thank
You're all
you.
tired of listening by the time I get
Yes,
up
you
there
should go
every
first.
month. Okay, I'm almost
That's a blessing.
I'm almost done. Just two more things. Our aging division, our deputy administrator position is now posted. Our protective services supervisor position, I think, which you had asked about a while back, was posted, and we had no qualified internal applicants. I believe we had one applicant, but just didn't meet the minimum education and training requirements. So that will be posted externally. So we are really anxious to kind of get some of those final key positions filled there, and we did have one recent retirement within our aging division, but it was a caseworker, it wasn't another supervisor or high level position, but nonetheless just as critical, because it's one of the folks who does the all that daily casework. So, but we're continuing to plug away there. Children and youth, I just wanted to mention one of the new programs that we started we contracted with St. Luke's and their visiting nurse association, I think it is. We use them. They're part of our child death review team. When we have a near death or fatality in a child, they're just part of the team who investigates is not quite the right word, but we'll use that word. So we have a very good working relationship with them. But what we found is there's so many, especially with the opiate crisis, there's so many kids now coming into foster care that have medical issues that caseworkers are not equipped to always know and understand. So when we get investigations that we have to do, and we get 100 pages of medical records, we happen to have 2 EMTs in our children and youth department who can sort of help muddle through it, but we really needed some more expertise. So they just started, and eventually will be there full time, and they've already proven to be invaluable with some of our investigations and some of their medical knowledge and things to look for, things to ask doctors follow-up questions about. So I think that's going to be a really exciting, helpful tool for us moving forward.
Do they report to the state, or do they collaborate with the state? Because I know in
Who's
New
they?
Jersey, the VNA nurses or the child mortality or the death review.
The death review, I think there is someone who is, I'm sure there's someone, and I think I even know the name from the state, who sits on that team each month when it feels like it's each month, but it really is only when it happens. They sort of go in spurts. And my last thing is, it wouldn't be a meeting if I didn't complain about civil service. So this time, forget it, children and youth is still a problem. But we're trying to get a clerk 3 in our aging division. Our clerk 3 took over for our retired senior center director months ago, 4 or 5 months ago. And it has been nothing but a debacle trying to get a list from civil service. So we tried yet again, and they closed testing. So testing's not even open for potential clerk 3s to take the test. Yes. So, they're going to, 1 and 2 clerks are open all year, but clerk 3, twice a year is sufficient, Mr. Kraft. So I am told at least that if they cannot come up with any names from previously, that they will reopen testing. But I have to highlight the just daily. So Georgine, God bless Georgine, my secretary, though many of you know her, I couldn't survive without her. She's doing her job, that clerk's job, which is enormous, as well as the HR analyst's job, who used to be in my office and has not been there since at least 9 or 10 months.
Excuse me, can you file a hardship? I mean, there was a little caveat at one time where if the test wasn't open and you had a real issue, there was this little back door, not that it was always open, but,
Yes.
oh, okay. I was
Yes.
just-
No, I think there's a way around it. It's just constantly another hurdle, another hurdle
Yeah.
to jump, so.
That's the state.
Yep. Any questions?
Thanks for all that you do.
You weren't here for my new position last night, Mr. Kraft.
I was with my grandson.
Good, that's better.
Yeah.
Thank you.
You could go first next time. Would that be better? No. Thank you very much. Motion to adjourn or move to adjourn?
Yeah, sure, you don't need to.
Thanks. Adjourned. Bye.
I want to hear Mr. Durden give a report on the archives.
You should probably add it to a finance committee agenda. Put it on a finance committee agenda.
Meeting adjourned.